Hi, this is Colleen Parsons with Head and Neck Vessels Lecture Part 3, which corresponds with your cardiac assessment. The only thing you'll need for equipment is your stethoscope and good eyes. So we've already learned some of this when you did your head and neck assessment. As far as your vessels and palpating, you're feeling differently probably than you did before, but you can again begin to see how things intertwine, your assessments intertwine. So you're listening with your stethoscope to your neck vessels, paying particular attention to any extraneous sounds you might hear, such as bruits or murmurs. You're watching the neck vessels, looking at them from a 35 to 45 degree angle whenever possible. You should be able to see pulsations. You might be able to see a higher venous pressure, depending on the position of your patient. You're inspecting for internal jugular vein pulsations. You might be able to distinguish the internal jugular vein pulsation from the carotid artery. That takes a bit of practice, and I don't expect you to be able to see them. I'm going to look at jugular venous pressure, but that involves a higher skill level than I'm prepared to teach you and that you'll need unless you work in a cardiac specialized area such as a cardiac unit or a cardiac healthcare facility. So looking here, you've got your jugular vein, and this is your carotid artery. This is your jugular vein on this side, and you're looking for symmetry. So it's a little tricky to feel symmetry when you're not able to palpate simultaneously, but do the best you can. Inspecting the anterior chest using good eyes and sometimes very good lighting. Lighting will make a big difference, especially if you're in a cardiac specialty area. You are going to palpate the chest area, and we palpate a little differently. We're just using, well, they say use all 4 fingers. I use 3. But you're just palpating the area around the chest by lightly touching with the whole of the fingers instead of pressing down into the skin. When we're listening to all 4 valves, we are listening to the aortic valve, the pulmonic valve, the tricuspid valve, and the mitral valve. In that order. So the aortic, pulmonic, tricuspid, and mitral. Sometimes the mitral might be better heard depending on the anatomy of the person. Is tucked up. You'll very often on a woman, especially a large-breasted woman, you'll have to maybe even move her breast tissue out of the way. It's really easy to ask her to move her own breast tissue out of the way if she's not wearing a bra, which is likely with your patients who are wearing their gowns, and or just slip your stethoscope up under there. Doing it enough times, you get that confidence that you're just listening for that. You're not really touching anything but fatty tissue, and Sometimes you can hear it a little bit better, more to the side of the patient, depending on their anatomy. And you're going to listen backwards as well, using the bell of your stethoscope. Then you're going to listen to the mitral valve, the tricuspid valve, the pulmonic valve, and then the aortic valve, or aortic area. You're listening for S1 and S2. You're going to be listening to them separately. So you need to listen for a few seconds. This is not a quick thing like you're used to having maybe in your routine healthcare evaluations with your physician. Unless they're hearing something wrong, they don't usually listen for very long. But you don't know what normal sounds like, so you need to listen until you are sure you are hearing normal sounds. So I would expect you to listen for no less than 10 seconds on each valve area, so that you're hearing the S1 and you're identifying that and you're hearing that, and then you change to S2, and then you're listening just to the S2 sound, so that you're hearing things differently. And then when you go back, you're listening for the extra heart sounds when you're using your bell. You're going backwards, you're listening to the extra heart sounds, and for murmurs. We're not going to be developing any real competence with infants. Know that their heartbeat is significantly faster, and you will be assessing that and learning more about their assessments when you get into pediatrics, which is in your next year, in your junior year. Murmurs are, like I said before, apt to resolve in 2 to 3 days after delivery when the anatomy changes. However, you want to have them evaluated, because the sooner we know about them, the better for the infants. Pregnant women have a whole different set of issues with regard to their cardiac complications and assessment. Listening to their S1 is going to be different, and if you know anybody who's especially in an advanced stage of pregnancy, you really do want to listen to that so you can hear how different it is. And you can hear S3 sounds much more easily on a pregnant woman than you can on a healthy non-pregnant person. You will probably have the best opportunity to gain practice listening to aging adults, and especially among your patients. So I want you to really listen, not just to your patients, but any other patients when you're on the floor that your clinical instructor will let you listen to. The more you listen, the more expertise you gain with cardiac assessment. You can't be afraid of going in and not knowing what you're doing. Not knowing what you're doing is the only remedy to that is to do it enough until you know what you're doing. Culture and genetics is important as well. We've already reviewed these things. There's your sample charting. And these are just some other extra sounds that you may hear. If you hear them, make sure that you're listening to the skin of the patient and not through clothing. When you hear these, you can hear weird sounds when you're listening through clothing or when something else is going on. So again, the more in the room. So the more experience you have, the better you're going to be at listening for this. Listening carefully and listening for long enough So 15 seconds on each valve is not too long. There are all different kinds of things that can go wrong. So in summary, your checklist, you already have your assessment list. So heart assessment, but not the end of your cardiac assessment. That continues with your peripheral arteries.